I'm so glad to see people in our chairs here in our auditorium. It's very exciting. I'm Pam Cipriano, Dean of the School of Nursing, and I'm just so pleased to be able to welcome you to the Catherine Strader McGehee Memorial Lecture today. We are just so glad again to be able to gather together. And I want to tell you a little bit about the lecture first before we introduce our speaker. So this lecture series is named for Kathy Strader McGehee, who earned both a BSN and an MSN from UVA and was enrolled in our PhD program when she died of breast cancer in 1999. She left behind her husband, 3 children, and a loving extended family, who together with her friends and members of the BSN class of 1975 endowed this lecture in her name. Kathy lived her life being true to her beliefs. She was a teacher at heart and was an associate professor of nursing at Lynchburg College. She mentored others, volunteering in local schools and working closely with adolescent girls. And she served her community and helped establish a free clinic in Lynchburg that continues to operate today. This lecture offers a forum for similarly driven, distinguished nurses, healthcare experts, and leaders who are recognized for their personal qualities that Kathy demonstrated in her life. A firm commitment to excellence in nursing education and practice, and an unwavering desire to contribute to others and the community. I'm so pleased that many members of Kathy's family are here today with us, coming from near and far. So please recognize our distinguished guests. Thank you so much, and thank you to all who have made this lecture series possible. I want to introduce our speaker today, Dr. Ryan Shaw, an associate professor of nursing and medicine at Duke University, you know, that blue university down the road. He is a nurse scientist who personifies the same commitment to excellence in education and practice and sharing his expertise with the greater healthcare community. Dr. Shaw's work is informed by the analysis of patients' individual health data gleaned from high-tech mobile devices people wear or adopt into their living environments to improve their quality of life and outcomes in the face of chronic illness. And we know this is clearly the wave of the future. There's a lot that exists now, and he's going to tell us how it's working and how it's going to improve care. As we know, a growing portion of Americans are living longer and with 1 or more chronic illnesses. The CDC now estimates that more than half of our population, 52%, suffers from at least one chronic condition, from arthritis to diabetes, COPD to cancer, asthma to kidney failure, and that more than 1/4 or 27% of us have more than one chronic illness. Recognizing the utility and importance of embracing remote and mobile personal devices, Dr. Shaw's work is helping to ease the burden of chronic conditions. As an alumnus of Duke's School of Nursing, where he earned his PhD, Dr. Shaw also spends time mentoring like-minded nurse scientists and innovators. In 2020, he founded the School of Nursing's Health Innovation Lab, what is called a maker space, where students and faculty can imagine, prototype, test, and refine new technology. And that's harder to do than you would think. Everyone thinks innovation is great, but actually creating that startup and getting everyone to be able to be supported is quite an endeavor. Dr. Shaw has received funding from the National Institutes of Health and the Agency for Healthcare Research and Quality. Currently, he's primary investigator or co-investigator on 7 grants, including one focused on detecting COVID-19 called COVIDentify, another focused on collaborative weight loss called Log to Lose, I want that one, and still another that aims to help Black men manage type 2 diabetes using mobile health technology. Dr. Shaw teaches health informatics, quantitative research design, and healthcare database systems courses in both Duke's School of Nursing and School of Medicine. He's a member of the Duke Center for Applied Genomics and Precision Medicine, and associate of Duke's Initiative for Science and Society. It is with great pleasure that I introduce Dr. Shaw, our 2021 Catherine Strader McGehee Lecturer, who will talk with us about digital health from research to implementation. I'll turn it over to Ryan.
All right. Well, thank you so much. It's really a true honor to be here, and thank you to Dean Cipriano for this invitation, and for all of you who are here today. This is actually my first in-person event like this in over 2 years, so I'm really excited to see people because we aren't on Zoom, so I'm thankful for this. So I'm excited to talk to you today about what is digital health. I'm going to first talk about what it is, a lot of the recent trends that we have seen, especially since the pandemic started. And I'm going to show you some different examples of the research that we've been doing in my lab. So I'm just going to. Sounds good. Good. So I'm just going to start here. These are our patients. They are connected. They are younger. They're also increasingly older adults as well, and they are increasingly connected too. And the data shows that this is true. Most US adults own at least a basic cell phone, and this transcends rural, urban, and also rural and also urban settings, including socioeconomic backgrounds, and increasingly adults own smartphones too. Over 85%, including rural areas too. And the most important thing here is that this transcends socioeconomic backgrounds, most racial, ethnic backgrounds, and increasingly geographic locations too. And increasingly, people have in-home broadband. So from a data standpoint, I don't really think about this so much as a phone. It's opportunity to collect health data from people increasingly in their everyday environment where health happens, right? Now, this isn't everybody, and there's still this a digital divide, particularly with the in-home broadband and with smartphones. This topic even came up last night during dinner, talking about access. But if you've been paying attention to politics lately, there is this massive infrastructure bill that just got passed with like $65 billion to expand in-home broadband. So if we look towards the future, hopefully this will grow. So this is opportunity. That's all that it is right now. So digital health is this idea that we can connect and we can empower people and populations through what's called digitally enabled care environments. So we can leverage tools to collect data from people, again, where health occurs. And so when we traditionally think about healthcare being delivered within clinics, hospitals, we can begin to rethink about where and when we might collect health information. And so we can potentially create new care delivery models that, again, begin to meet people in their everyday lives. And so there are many different health data types, and these are things that we may often think about being collected within clinics. These might be surveys that you could collect on a phone, patient-reported outcomes, maybe on a tablet. This can be given in a clinic. It could be given while someone is at home, while they are traveling. The technology really doesn't care. It might be things that you can wear, like a watch that could monitor heart rate, maybe even a blood pressure. Increasingly, it is voice-activated devices too. So you might have Alexa in your home, which might sound a little scary, that it might be involved in being able to deliver healthcare. But you can imagine you go through surgery, then you are discharged home, and maybe you respond to. Maybe you will respond to it about how to care for your wounds, or maybe a medication management too, and increasingly environmental sensors. And there's a lot of work being done here at the UVA nursing school around that. But it's more than that. It's a lot more than that. It's FDA cleared electrocardiograms that can tether to your phone. guess I didn't bring it, but you can even do 6-lead EKGs on these devices. And it creates this circuit that you might hold out this thing, it gets the data, and then it can tether to your phone, and that data could be transmitted into the electronic health record. It's stethoscopes that are now wireless to listen to breath sounds, bowel sounds, etc., heart sounds, and that data doesn't have to just stay there when you listen to it. It could be transmitted out. So if you're in the hospital, a doctor, a nurse, anyone could also get that data in real time and it gets stored, or when someone's at home. So we can begin to think about new ways in which we might collect this information. And there's also exam kits. So this is from a company called TytoCare. I don't have anything to do with them, but the idea is that you can look into people's ears, their mouth, and it's a video that can get transmitted out. So you can do at-home telehealth with a physician, a nurse practitioner, or someone over video, and they can see things in real time, or in the hospital too, right? It doesn't really technically matter where this is as long as you can get that data. So we call this patient-generated health data. And these are health-related data created, recorded, or gathered by patients or from family members or their caregivers to help address some health concern. So it doesn't necessarily have to be the patient themselves. We could find another person to also collect that data too. So for children, it's probably unlikely that they can always use these things, but maybe their parents can, or for much older adults too, right? So it's not this one size fit all. We really have to tailor the data and the devices to both the population and the clinical need. We also might call this patient-reported outcomes, PROs, among other things too. So a digital health is this idea that we can access patients in their everyday environments where health occurs, and we can better continuously measure manifestations of their disease, and we can better characterize their frequency, length, and the content of their symptoms. And the big goal is to be able to predict when clinical events happen. So if we are monitoring people more, we have more information about them, and we may be able to see signal when some event might happen to maybe prevent emergency department visits, urgent care, or maybe worsening health, because you're getting information about people. And so we believe that this is going to be most useful in long-term chronic conditions, like for mental health care, for depression, diabetes, hypertension, arthritis, etc., where people are often living with these conditions for quite some time. And if we can get data from people where they live, we'll know more about them. But also for acute care too, post-surgery, right? We might discharge someone home and we begin to continue to monitor them. So maybe a nurse would call them up if they see that things might be getting worse, or they have that telehealth appointment and they may or may not need to come in. The idea here is not to replace care at all. It's to increase access to care. So, and I'll also come back to that. So here's a model that I like to show, is that you can think about patients across across all stages of their life, and you customize the monitoring towards them, towards their age. Could be a prenatal, postnatal, all the way through adulthood, and they could wear devices. It could be in their home, maybe even in their car, or in the hospital too. And you got to figure out, and this is a big challenge, is how do you pull that data back to a central database, which could be their electronic health record, and then you can apply data analytics to that and look for patterns, and in a feedback loop you can deliver care to people. And so this is just kind of a general conception of really how this stuff works. So most recently, probably the biggest application to this has been around telehealth, which is the delivery of these health related services via telecommunications and via digital communication technologies. And telehealth is not necessarily new. It's been around for a while, but recently it really took off, right? And so when the pandemic hit, all of a sudden, we had to promote social distancing measures. So clinics were then essentially replacing care that would be in person via video or via a phone call, right? And so I've heard from many people saying that, well, it's great that I can still see you, but I can't hear your heart sounds. I can't take your vital signs. Like, it's kind of half-baked often. So we swung all the way from people doing these telehealth visits in these health systems almost scrambling to figure out how to do this. We had nursing staff that would just be almost immediately shifted over to be able to deliver care in this way. But there wasn't necessarily infrastructure built to truly do this. So the government started to really invest in this. And one of the biggest things is that they allowed a reimbursement, right? And so that really opened this up during the public health emergency. And the FCC also funded different clinics and these health systems with devices and to build infrastructure to be able to do this. Now, the big question is will it continue to be reimbursed? It's a huge topic right now, to the point that there are over 1,000 bills pending before state and also federal lawmakers. And so, yes, the money is a huge part of this because it has to be supported. But at this point, we're kind of assuming that it's going to stay in some way, in some form or fashion. And Arizona has probably been the most radical state so far, where really a physician can practice in Arizona delivering telehealth. They can live in any other state. I'm not sure about practitioners, but I would assume it's something similar. So it's already here, and it's likely to stay too. And so what this is doing, it's increasing access to care, and it's allowing us to deliver new care delivery models. For example, for a population health, if you're a clinic and you have a panel of these diabetes, or if you have patients who do have diabetes, you can begin to remotely monitor them to collect glucose data, blood pressure data, etc. And you can manage them from a population level to be able to direct resources and to be able to help people. There's also this shift to the home as the care site, and I'll talk a bit about that. But there's also this increase in the clinical workforce that is needed. We need more nurses now because we're getting more data, and we are delivering care while people are at home too, right? And there's going to be needs for new clinical education around digital health. Also, we need to train clinicians to be able to deliver care remotely, but also be able to deliver care in people's home that we would traditionally do it within the clinic or within the hospital setting. So in some ways, we're almost reverting back to the old days, long before I was born, when you would go to people's homes to deliver care. Not that that's completely new, because we do have home care, but we're shifting the care that we would normally think of within clinics and also to the home. And there's also this big policy development and change. So some examples are the home as the care site. What this is, it's this hospital at home program would be one example, where there's this shift from acute care, where say a patient is admitted to the emergency department, they might have heart failure, and instead of admitting them to the hospital, they are sent home with a suite of these remote monitoring tools. So it could be this iPad with this cellular-based connection. You might have a blood pressure cuff that is tethered to that. You can measure oxygen, temperature, all sorts of things, and they go home with that. And the nurse would visit them 1 or 2 times per day in their house. Maybe the physician goes by there too. So instead of being admitted into the hospital, they get to be discharged home. And so these models where we're shifting acute care back into the community in this way are increasingly growing. But also you can do at-home lab tests. The nurse can come into your home. They can take vitals. They can take labs. And this is big business. Has anybody heard of this Amazon Care? Are you familiar with it? Some people, yeah. So before the pandemic hit, this was announced that Amazon was going to be offering what's really this concierge services to their employees in the Seattle area. You download an app on your phone. You can talk to a nurse practitioner, or perhaps somebody else. You can do video care. You can do a 24/7 chat, text messaging, and they'll even go into your home, take vital signs, take your labs, and you never have to leave anywhere. You might just be able to stay home, particularly for a primary care or for these conditions that aren't too acute. Right. So it's not to replace care, it's to augment it. And I don't know if it's true, but if you have Amazon Prime, you might even get free deliveries for your medications. So, and the reason why I bring up this example is it's usually kind of jarring for people to think about Amazon in this way, but they're expanding to all 50 states. So far, they're in over 33 states, and they're trying to bring on companies to buy into this model too. And I believe Hilton signed on yesterday. That was announced. So, and it's not really just about Amazon. It's to demonstrate that this model is growing. And this is just one example. There's also a Walmart's doing this too. But there's companies like, for example, Teladoc and Livongo, where it's this hybrid model of being able to remotely monitor people, and you tie it into this care delivery model where people may go into your home. And so not only is this not just coming, it's already here. A Teladoc is like a $38 billion company now. So health systems are now competing with almost these new age type of ways to deliver care. One of my colleagues who's a physician, we were working together on this trial, and he got a job at this company called One Medical, and it's mostly telehealth-based services, but they partner with these health systems as this augmented care in case we don't have enough primary care visits. So things are changing. That's what the message here is. So a little less than a year ago, we got funding from the federal government to do this nationwide environmental scan to see how much this is truly going on. And we're trying to figure out what patient-generated health data from these devices and everything else is actually being pulled into electronic health records, which is hard to really know what's happening in real time. We did a review from the traditional literature, which was not that useful because this stuff doesn't often get published on from a technical standpoint. We looked at guides and resources from the government and different organizations. But the most interesting thing is I did interviews with the major EHR vendors in the US and from some smaller ones too. I can't tell you their names, but I'm sure you could figure it out. And they said, yes, there is a lot going on right now, and that the US healthcare system is in this huge transitional period where data that was traditionally collected within clinics is now increasingly being collected within everyday environments of the patient. And COVID-19 has been the accelerator, both from a physical standpoint, but from a funding standpoint, right? There's this growing adoption that we need to have data standards so that we can communicate between systems. And if you're not too familiar with how electronic health records work, it's really, you can and you can't share data with other health systems. It's not that simple. And you could be working with the same company, and it is still big. There's still big barriers there. So there is a lot of work going on from that. Though it's not all rosy, right? Even though we're in this big transition period, a lot of these devices, the data, they create burden, both on patients and on the clinical teams, which haven't necessarily been taught how to use them, how to deal with all this data that's constantly coming in 24/7. We need policies on like, how do you deal with high values and low values? Who's going to support this care at 2 a.m. that's coming in? So there's a lot to this. We also have to make sure that the design and the implementation works for patients from diverse backgrounds. So we have to focus on usability and workflow integration. And while there's the potential to reduce health disparities, there's also the potential to increase health inequities, right? And so we really need to focus on that. And we really need to focus on quality and on cost effectiveness. So there are a lot of different challenges, security and privacy. We get asked a lot about that. I feel like that's half of my life is dealing with that. Data burden, data quality, and I'll go over that in just a bit. How do you convey information meaningfully, both from the clinical standpoint, but from a patient standpoint, and patients from different ages and different backgrounds too. Again, we need to invest in broadband, which is thankfully changing, affordability, and also literacy and usability. So I'm not going to focus on most of these right now, as I just don't have time. But what I am going to focus on is digital health equity. So there's still the digital divide, particularly often for the most vulnerable patients. We need to make sure that people have access to digital health, that they can afford it. And we really need to engage with diverse communities. Many of these devices and tools aren't necessarily designed with or designed by the people who are going to use them. They might be designed in California, in Silicon Valley, and only tested on people with certain skin colors and certain genders, maybe only white men. And so that doesn't necessarily meet the needs of patients that we're trying to help. That also we need inclusive design too. Not necessarily can everyone use a cell phone like this, right? It might be too small, you can't see it. There might be and if you shake or you have a dexterity issues, you have to take all of that into account too. And again, literacy is a big thing here. And I think about my mom when I'm doing these trials, and I'm like, gosh, how can I actually teach my mom how to do this? She sends me emojis now. We've come a really long way. She sends them all the time now, and I'm thankful, gosh, to have her download an app and to use this. And so, I always like to run things by her. So this is a new article that just came out last month from a team up at Mass General, and it's a really good example of how we can actually create digital disparities without even knowing it yet. And I'm going to briefly walk you through this. So up at the top, when patients would go into clinics, they would give them tablets to complete patient-reported outcomes. Could be surveys about all sorts of things. And then when the pandemic hit, they didn't want to pass them out anymore due to the social distancing measures, and you can see that it really plummeted. So the idea was that, well, we'll just have people go into their patient portal, and they will just complete them there. Well. So you can see where it started here, and from around April to January 21, we start to have this big divide between racial groups, right? And so up at the top, we have white and also Asian. And so these patients are more likely to go into the patient portal and to complete this. But among their Black patients and the Latino patients, it's a lot lower too, right? So they're not getting the data from the patients in this way. And so this one size fit all approach that they all of a sudden did actually started to increase health disparities and created inequities. So I thought was a really good illustration of how we really need to be thoughtful about how we approach these tools, and we really need to engage diverse patients from various backgrounds. So now there are ways that we can select tools, and we can select data that will hopefully give more informed decision making when to choose these tools. This was a paper that we published based upon implementing these remote monitoring technologies, and you are welcome to check it out, but it goes through many different aspects when we think about selecting these tools. One, can we get the data? How do we actually pull that in? We have to be concerned about is it FDA cleared or not? Some devices do have to be FDA cleared, some don't. It really just depends. We need to look at the clinical effectiveness, which can be challenging with these consumer-based devices. We need to look at the different economic aspects. Is it going to be, will your insurance cover it? Is it going to promote health equity, etc.? So there are models out there that can help guide us. So I'm just going to briefly show you a few research examples that we've been doing over the years. I'm going to start with this one here. This was from one of my former PhD students, and she was trying to figure out if these children who were going through this pediatric bone marrow transplant, could we better track their symptoms inpatient? And then also when they are discharged home, can we continue to track those symptoms? And so they had to be old enough to use this wearable to be able to track activity and also to be able to track heart rate inpatient. And they designed this, and then they designed this app where they could track how they feel. Children love emojis, so that worked out well. But also their pain symptoms and so forth. And so this went well. However, if the children are too sick, they're not going to do it. And their parents may or may not also, depending on how sick their child is. So really that acuity may impact how people use these tools too. But they were also discharged home with this too. And she was able to continue to track this data for 3 months post discharge. And we can do some interesting stuff with this. We can graph out symptoms. We can potentially overlay them onto clinical events like a transplant, et cetera. And the idea here is that we might be able to make more informed decision making, maybe even predict when things happen down the road, but that's for future studies. This was mostly feasibility to see if we could get this specific population to use these devices. Because we just can't put things on people. It doesn't work that way. So, this is a trial that we started back in 2016, which seems like ages ago when it comes to tech. This has really informed our current trial. And so we started this back in 2016. Technically, I wrote this in 2014. And the idea is that we would engage patients who have type 2 diabetes from different socioeconomic backgrounds and trying to figure out if we could get data from them using multiple devices. So they would respond to a text-based text-based medication adherence survey on their phone. We gave them this cellular scale right here. Then we could track weight while they were at home, activity tracker. We also measured glucose, and that tethered to an app on their phone too. And we were trying to figure out, could we get the data and could people use this over time? And can we reveal patterns within that information? But you also find out a lot of different quirky information about stuff. And I always like to share this story about the scale, which I thought I brought with me, but I think it's back in the room. So we give people this scale, and you never know what you're going to get because you give it to them and you ask them to not let other people step on it, but other people step on it, right? It's in their bathroom, or it's, somewhere in their house, and kids love to step on it, spouses step on it, anybody steps on it. So you got to figure that out, right? Like, well, how do you know whose is whose, right? You can create algorithms where you get someone's baseline trend, and then if it's in or out of a certain range, say 5%, it's likely not them, right? Because they're not going to gain or really lose that much weight within a certain time frame. And so we can get pretty good at that. And I always like to tell the story is that people also, what they love to do? They love to weigh their pets on these things too. And so what people will do is they'll step on a scale, they'll grab their dog and they'll step on it and it come off, and it's great. Big dogs are no problem, but little dogs though, I'm like, I don't know what to do about the little dogs. So I'm just kidding, but that's also a true story. So, but you just have to have some levity with this stuff too. So this was a smaller study. Really, it was just feasibility to see, could we even do this at that time? We recruited 60 people from the Durham, North Carolina area from this a primary care clinic, and most of these patients were able to use these devices. We could teach them. They would send it back to us. People were interested in being engaged, or at least being willing to learn. And so we found that it was feasible to do that from people from different backgrounds, and the data revealed notable patterns, though there were challenges with the data transmission reliability and the quality over time. And we also interviewed people to figure out, how should we display this back to you? So I'll just show you a couple interesting things, and I'll walk you through this. So what we were able to do is called digital phenotyping. And what it is, we were able to classify people into 3 different groups. So in this case, it's groups that engaged using the glucometer and the wireless scale. And we were able to pull people into 3 different groups: high engagers up and top, medium engagers, and then low engagers. And we could look at the characteristics of these people over time. And the most interesting thing is this group on the bottom here, which were the low engagers. So over time, they stopped using these devices, which we expect people, it's just going to happen. But those were young people, right? And we expected the opposite. We thought maybe older adults would not use these over time. And we got a lot of pushback on this. They're like, no way, that's not the younger people. That was the younger people, which is kind of wild. And so we don't really know why, but there's a lot of reasons maybe. Maybe they're younger, and if they have uncontrolled type 2 diabetes and you're 20, there's probably a lot more going on in your life. Among other things too. So it was interesting to inform the future of research. You also find interesting things within data. This is upon that scale, how I had mentioned, and you get this weight over time and you get these really low things. And so you just kind of have to figure this out. You have to test everything out. It just isn't going to work on its own. You have to look at these data anomalies. This is just an example of how the data can be messy. And you don't need to read into it too much. So this is one glucometer from one patient over 14 months. And you can track before lunch, after lunch, before breakfast, after dinner, and it's not that useful, right? It's like, oh my gosh, it's all here. Like, how do you make sense of that? How can you deliver healthcare for that? And we map the patient's hemoglobin A1C over that, and you can kind of see this trend. But the idea here is to illustrate that it's not that simple. You just can't get the data and you're just going to magically be able to know what to do with it. A lot of work goes into this. So we also have to figure out how we're going to visualize this back to patients. This is a current PhD student of mine, Anya Idiane, and she's specifically looking at how do we design these digital health interventions for Black men who have both or who also have diabetes, so that we can better customize the way to use these devices and how we might visualize data back to them, particularly within the patient portal. And what we'll learn from this will be useful for what we're doing at the end of the next study I'm about to describe to you. So our current big project is called Extend, which stands for Expanding a Technology-Enabled Nurse-Delivered Chronic Disease Care. This is funded by the National Institute for Nursing Research, and it's a 5-year grant. I'm doing this with my colleague, Dr. Crowley. And so what Extend is, is that for many people controlling their diabetes, it may be uncontrolled and they aren't necessarily responding to clinic-based appointments over time. So there's this population of patients that continually to remain with this in this uncontrolled state. And the idea is that using mobile technology could help improve their diabetes care and potential comorbidities, such as them having hypertension, which many of these people do. And so what this trial is doing is we're comparing 2 different mobile technology-based interventions, which I will describe to you. And we're enrolling 220 people, and we're going to be monitoring them over 2 years. And really, we're extending care to them. That's the concept. And our previous work shows that nurse-delivered telehealth in a veteran population can improve diabetes outcomes over 12 months, to the point that that model is being rolled out across 12 VAs around the country. We're bringing that over to the private sector, and we're modernizing it, if you will, by pulling in data from these various technologies based upon the previous trial that I had just talked to you about. And so I'll go through this quick. So the idea is we're going to compare the effectiveness of these 2 12-month interventions and look at the outcomes on hemoglobin A1C, blood pressure, and also weight. So that's more of a traditional research design. And what I'll talk about in a bit is we're also implementing this within our health system. So as we build it, it's part of the entire structure. So other clinics will be adopting all of this infrastructure too. We just happen to be first in line to do this, which is a really interesting design here. And so the first approach is patients will be randomized to 1 or 2 approaches here. They will receive 4 different devices, pretty much just like before too, to measure glucose, weight, blood pressure, and their activity. And we pull that data into their electronic health record. It's a lot easier said than done. It's taken us a year to do this, contracts, all sorts of things. It's a lot. And so half of the patients will be randomized to this group, where they will still go to their normal clinic appointments, but they are going to use these to potentially self manage over 24 months. Oh, sorry, I said it there. Yeah, same thing I just said. 2 years. And then in the second sorry, probably should is this nurse and pharmacist-based telehealth care delivery model. So these patients aren't necessarily they aren't responding too well to their clinic-based care. So a nurse will call them up every 2 weeks to deliver this evidence-based telehealth, reviewing medication management, diet, exercise, etc. But they'll also see all of the data from all of those devices within the patient's electronic health record to have more informed care delivery then. And then the nurse then writes a note within the electronic health record, and they forward that to a pharmacist. And our pharmacists are being credentialed by the state to be able to prescribe medications. So this happens every 2 weeks, and it's not to say they're going to be doing too much in a one time, but the idea is in between office visits, they are getting this more intense care. So we're testing this telehealth care delivery. Okay. Oh, sorry. And so this is another example of really how that works. We pull the data in from the devices. The nurse delivers this visit. And in case anyone is interested in this, the nurse prescribes the devices. So when I say they prescribe them, and I don't know if you can see this, but you have to indicate how long you're going to use them, if there's any values that are too high, and for how long are they going to be too high for, such as having high glucose, who gets alerted. And so the system has to process that and alert somebody. So we have to figure all that out. It goes to the nurse. What happens if that happens at 5 p.m., at 2 a.m.? These are all legal questions too. And so I didn't quite expect I would fall into all of that too, but these policies that are being developed are being used for all of the clinics. And we're also visualizing this too. So when the nurse has this conversation with the patients via this telehealth visit, it gets visualized in this way. And this is just an example of what it'll look like for their blood pressure. We have to do this for all of the devices. And I don't even know, we're not going to get far enough to combine them all at the same time too. So if anyone wants to do data visualization work, just let me know, because we're definitely looking for collaborators. And so that model keeps going, where the nurse works with the pharmacist, and it's this cycle over 12 months. And so probably the most interesting thing is we're going to take all of the data from those devices, and we're going to see if we can predict when patients have urgent care visits, emergency visits, or when they might be hospitalized over those 24 months. I'm not going to go into this too much, but it's called dynamic risk prediction. You look at that event, and those devices have a signal in them. Whether we get that data or not, there's going to be some pattern in there that's likely going to predict when some event might happen. We can't do it yet because we don't have this data, but I think this is really fascinating, where we maybe would have some alert, and maybe a nurse or a physician would call up that patient and say, hey, I see this trend within all of this data. Do you need to come in? Do we need to talk to you more? So this idea to move towards a more proactive health system. And then the last thing with this is we are looking at how we are implementing this and how we can scale it. So this is being implemented at 5 clinics, and they're foregoing this new population health management program. Instead, they're going to allow us to roll out this study there. And so we document everything, all of the different policies that get decided, how we build the IT infrastructure, how patients are going to consent to this. And as we go along, we document all of it. And throughout this process, we will be interviewing patients, IT stakeholders, administrators, et cetera, to really look at this. And we also are looking at how much this costs too. And so how much this costs compared to current current mechanisms to get paid for this. And it's really interesting because we don't completely know what all of those are yet, because there's so many telehealth bills out there. So it'll be really interesting. So and it's just things that I never thought we would get involved in. And so when you prescribe all of those devices to patients, they have to agree that you're going to not only allow them to send in the data, but potentially they have to pay for that. Now the grant pays for this, but in the clinical area, and I just put this up here as a good example, is the compliance department and the legal department has to approve all of this verbiage. So the patients have to agree that they're going to pay for it. Now their insurance might pay for it, CMS might pay for it, but we just can't put that on people too, right? There's all of these economic implications too. I just thought it was interesting, like we had to cross out that line and we do all these things. And so it's just really interesting. And so In the patient data visualization part, I put that as a star on there because that's not part of this study, but it's happening anyways. So the data is going to come in, the nurse is going to see it all, and the pharmacist too, and they're going to deliver that care. But in the patient portal, the patient's going to have all of it access to, and the health system is doing it anyways. And so I'm like, gosh, we need more funding. So, but anyway. So in summary, healthcare is evolving, and it has been accelerated by COVID-19. And we are really witnessing the implementation of these digitally enabled care environments. There's a lot of different opportunities here to enhance care, to improve and hopefully sustain health outcomes. That's why we should be doing this, and hopefully to provide more equitable, accessible care. But it's still challenging. I mean, we don't really know what the long-term outcomes are. It's still fairly new. Accessibility issues could be a problem, technical illiteracy. How do you visualize and deal with so much information? Security, privacy, and more. And just something that I always tell everyone that asks me is that don't focus too much on the technology itself. It's changing every year. These companies are putting out new models. Just focus on the data and the methods. And by the time a few years go by, you'll be able to hopefully repackage that for the care delivery that you are interested in. So I don't do this by myself. It's big teams, between 10 to 20 people, but I'm also thankful for my family, the many patients that are involved, and really all of my different colleagues and my students too. So I'll include some references here if you'd like to go back, and I'm happy to take questions. All right. Thank you.
So I appreciate the challenges, many challenges that you have, and but my question is kind of a sidestep over to the glucose monitoring and what we do today with finger sticks. So whether or not this is in the hospital or this is out remotely in the home, what we're doing today with finger sticks is just crazy. And I know during the COVID time, FDA fast tracked some approval of some non-invasive monitoring.
Yeah.
So with your monitoring that you're doing, have you looked at non-invasive? Is that something that you think is in the near future for hospitals as a whole? Or do you think we'll still be stuck with finger sticks, so to speak, over the next few years?
That's a great question. So currently for this trial, we are going to be giving people glucometers where they're going to be doing the finger sticks because we're meeting them where they are right now. However, patients are increasingly using these continuous glucose monitors, which are actually, quite frankly, better for people if they can learn to use them because you can see the fluctuations in real time. So that's becoming more common. But also, there's a lot of different investment in this non-invasive glucose monitoring too. And there's potential patents from, say, Apple, where a watch could potentially measure your glucose from the blood sugar, from the sweat in your skin. I don't know any more than that, and it's still kind of like, is this really going to be true or not? But I think that would be great. Yeah, no one likes to prick their finger. It's not fun. It's not always the most reliable. So we will evolve, or as that changes too. So yes, it just depends on what comes out on the market. So yeah.
Great talk. Thank you so much. I had a question about the data visualizations for the Extend trial, and certainly can appreciate how much complexity there is around that. But I'm curious about the visualizations or the data that's being pushed to the nurse and the pharmacist. Are you thinking about, or maybe you already are, getting feedback from those end users about the data visualizations, or in terms of how they're being produced and consumed?
Yeah, it's a good question. So unfortunately, our control over this is limited to the electronic health record system that we are working with and the contract that they have with the company to pull in that data. So at least for now, I'm trying to help with the most informed decision-making on how we're going to visualize this. And so this will be as good enough as we can, because this is both for the trial and in a practice too for all of the other clinics. But yeah, we'll be interviewing patients about were there better ways to do this? Could it be more informed for you? There's 4 devices, so how can we all combine it? So there will be more grants down the road too. So we're constantly dealing with what can we do now in realistic within the budget versus we have to pull it off, right? Unfortunately, and that's just kind of how it is. But answer is yes.
So Ryan, I have a question about the workforce issues. Obviously, we do things now today as consumers that only health professionals used to do in the past. So you've repeatedly mentioned nurses and physicians being in this chain of events. Are you seeing a trend, though, that certainly family home caregivers, as well as perhaps a new emerging sort of tech assist person, really becomes the intermediary? Because when you say we need more nurses, I'm sure everybody here goes, "You got to be kidding me." So what are you seeing, or what would you anticipate is the trend in order to be able to have this extension of so much care out where you live?
I'd say all of the above. So family members will need to be part of this, right? And also caregivers, particularly for certain conditions where they will need to collect data on behalf of people too. Yes, this will increase burden on nurses to be able to do data management and be able to use it for clinical care. However, so what our health system has decided is that there's going to be this virtual care team, which isn't a nurse. It's really these technicians. And if the clinics prescribe these devices, the algorithms are the first line of defense, if you will, to say if there are these trends towards high values or low values. And then it goes to this technical team, because the patients are going to call up on the phone saying, "Hey, I need help with the app. I need help with this." And the nurse does not want to deal with that all the time. In fact, we don't have enough nurses. And so there's new job opportunities around like health tech, which is interesting. And we'll have to train those people. And where are they going to get trained at? This is all brand new. And it's a lot of questions about where is that level of the responsibility where we do need to respond versus normally we just tell people to call us when you need us. But if we really do have the data and it's showing something, who is supposed to respond? So yeah, we have these conversations a lot. They create delays within policy development. But I hope that answers most of your quick questions, but yeah, there's a lot that's coming.
Thanks. I'm curious whether you're finding the insurance companies supportive or a hurdle that you're trying to get over.
Yeah. So insurance companies, so when the pandemic hit, not just CMS, but the insurance companies were allowing people to deliver telehealth, and it would be reimbursed. And there were a lot of reasons why they would do that. Insurance companies are now stepping back and saying, if you don't have a good internet connection, that's not good enough for us to be able to reimburse telehealth. So there's a lot that's still in flux right now. It varies by your state. It varies by your insurance company too. We also need more evidence that the telehealth works well versus just asking patients to come in. So it's still a pretty gray area right now in terms of what's actually going to stick, if you will, versus what's going to be allowed. I'd say for mental health care, that's one that is probably unlikely going to stay around for being able to deliver telehealth-based services. Not to say that people shouldn't be coming in person, but if you live in a rural area, it really might be more convenient to have a video chat with people, just as a example. So it depends.
Thank you for those great questions. And I want to have everyone thank Ryan for his inspiring talk and showing us a little bit of the future. As he said, some of it is here now, but it's this kind of research and being able to look at how we modernize and use innovation to really take advantage of the technology explosion that's helping every kind of healthcare provider and family and person be able to really see this explode. So Ryan, thank you so much for sharing your research and expertise.